Hello.
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 Hi. Can you see me? Can you hear me?
Yes.
Yes.
Okay. So we still have 1 minute to go. Okay. Can you see the screen, the slides?
Yes.
Okay. So I think we can start. It is 12:30. So today is the first lecture about heart failure, and it's about diagnosis. First of all, a few things related to the importance of the topic. This is a highly relevant topic because heart failure is incredibly prevalent, and it is also extremely important in terms of cost, socio-economical cost. So these are some statistics published very recently from the United States. You can see here there is a prevalence of 2.2% in patients above 20. So if you take all adults, of course, much higher if you limit this to elderly patients. And the incidence in patients above 55 is 1 million per year. So it's a huge problem costing tens of billions of dollars. That's from US, but it's true for any health system. And here you can also see from the same document the prevalence of heart failure among adults over 20. And you can see that, of course, in young adults, it is really rare, but then it increases, and you can see that, for example, after 60, the prevalence is significant already, 5 to 7% of the population, and above 80, it is 12-13% of the population, which is huge. 1 in 8 elderly patients above 80 has heart failure. Now, this is a registry, a large registry, also from the United States, close to 40,000 patients above 65 from 254 hospitals admitted for heart failure, and this is 10 to 15 years ago. And you can see here that the two main types of heart failure with reduced ejection fraction and heart failure with preserved ejection fraction, are almost equally represented. But what is more important is these numbers here. Sorry. Do you see the slides?
No.
I kind of lost it, so I'll do it once again. Now it's okay, you see it?
Yes, we can.
So the outcomes at 5 years, this is really daunting data. So have a look here, mortality at 5 years, more than 75%. So 3/4 of these patients are dead at 5 years. Also, if you see a composite, either death or readmission for heart failure, basically everyone, they either died or they were rehospitalized. So it is a terrible disease with a very high mortality and with a very high morbidity. Even if you don't die, you suffer a lot, you get readmitted to the hospital and lots of symptoms and lots of suffering. So it's really a big problem. Now, a few things going back, and I guess you've seen this, just to remind you about the way we work with this. So in cardiology, we use very much guidelines, and when you use guidelines, you have recommendations. Recommendations can be either about diagnostic techniques or about treatments. And we have 3 classes. Class 1, it means the procedure or the treatment is generally recommended or indicated. Class 3, it means the procedure or the treatment is not recommended. And class 2 is in between. And there you have 2A, where the weight of evidence is in favor of using the technique or treatment. And 2B, where the efficacy is less well established. And even the wording should be considered. This is a 2A wording. You should think of it. 2B is may be considered, so weaker. Now, this is important to keep in mind because whenever we make a recommendation to our patient, we think of this sort of things, and the strongest thing is a class 1 indication, something you should try and do because there is evidence it helps. And the opposite, class 3, it's something we should avoid because it's not recommended, either because it's not helpful or even worse, because it's harmful. And these recommendations are based on evidence. And the evidence can be very strong or can be weaker. The strongest evidence we have when we recommend the treatment comes from randomized clinical trials, large clinical trials that have shown specific treatment to be of benefit, and then this means highest level of evidence, quote A. In other words, if you have a recommendation class 1 level of evidence A, it is something you should really go for. On the other hand, level of evidence C, it means there's not a lot of data, but just consensus of opinion from the experts or from smaller studies, retrospective studies, which is rather weaker. And in between is level B, either a single randomized trial or large non-randomized studies. This is not specific for the heart failure lecture. However, it's important that you keep this in mind whenever you think of a recommendation. And in particular for heart failure, you will see tomorrow, you will have the lecture on treatment. We are fortunate to have many treatments for heart failure with reduced ejection fraction that are class 1 level A, which is strong because these were backed by multiple large randomized clinical trials. How do we define heart failure? Basically, it's an abnormality of cardiac structure or function that leads to the failure of the heart to deliver oxygen at a rate which is proportional to the requirements of the metabolizing tissues. Because that's the job of the heart, to deliver oxygen via blood to the tissues. So whenever the heart fails to do so, we can talk about heart failure. Or the heart may be able to do this with the cost of increased filling pressures. In order to keep a good enough cardiac output, sometimes the heart may need to increase the pressures, and this is also something that is not good. It keeps the cardiac output, but it has several deleterious consequences. So this leads to some of the signs of heart failure, which can be due either to reduced oxygen delivery, and that was formerly called forward failure, or because there is fluid overload accumulating, and this was called historically backward failure. And you can also have some signs related to the compensatory or adaptive mechanisms of the heart by trying to deal with these issues. So to define specifically heart failure, one key parameter is the ejection fraction. The ejection fraction is a percentage, is simply calculated as the difference between the diastolic and the systolic volume of the left ventricle divided by the diastolic volume. So in other words, is the stroke volume divided by the end diastolic volume. And it is a percentage. So normally this has to be above 50. And so if we have a patient who has heart failure and the ejection fraction is 55, we will call this heart failure with preserved ejection fraction, because the ejection fraction is in the normal range. If we have someone who has an ejection fraction of 30, this is reduced ejection fraction, and we call this heart failure with reduced ejection fraction. And in between, we have something like between 40 and 50% ejection fraction. This is an entity that we call heart failure with mid-range ejection fraction. This classification is very important because the treatment of the patient depends on his or her ejection fraction. For heart failure with reduced ejection fraction, we fortunately have lots of therapies that have been shown to improve survival. Unfortunately, for heart failure with preserved ejection fraction, we do not yet have a specific treatment, but rather we try to treat the underlying conditions, hypertension, diabetes, and so on. So it's important to keep this in mind. How do we make the diagnosis? Well, heart failure means that you have a clinical syndrome, symptoms plus minus signs, and then in order to establish whether this is with preserved, reduced, mid-range ejection fraction, obviously you need to measure the ejection fraction. And for that, we'll get back to that. You need to do some sort of imaging, usually with echocardiography. And then, if the patient has reduced ejection fraction, you already have a diagnosis because you have clinical syndrome plus reduced ejection fraction. You don't need anything else. Do you hear me now?
Yes, we can hear you.
Okay. Now, if the patient has a normal ejection fraction, the question is this truly heart failure? Perhaps the symptoms may be due to something else. So in order to assure that this is due to some heart problem, we usually look also for some other evidence of the heart problem. And this evidence may come in the form of increased level of peptides. I will get back to that. And at least one additional criterion related to the heart structure or function. Either there is left ventricular hypertrophy, or there is left atrial enlargement, or there is diastolic dysfunction. So the diagnosis of heart failure relies first of all on the clinical picture, symptoms and signs. Secondly, you have to do the echo to look at the heart, because based on the ejection fraction, you know where the patient belongs and it will guide your treatment. And then most often we also have to look at the heart searching for structural or functional abnormalities, and I'll get back to that in a minute. Now, about classifications. This is one that you already know. It's quite commonly used, the New York Heart Association functional class, and it's quite simple. Class 1, it means no symptoms, no limitation of physical activity, ordinary activity doesn't cause dyspnea, fatigue, palpitations. At the other end of the spectrum, class 4, the patient is unable to carry any physical activity without discomfort, so symptoms at rest usually. And class 2 and class 3 are in between. Class 2 means slight limitation of activities. Class 3 is closer to 4, and it means marked limitation of physical activity. However, both are comfortable at rest. So this is very often used, and it's very easy to obtain because it's only based on history taking. You talk to the patient tells you how he feels, when his symptoms occur, and so you know the New York Heart Association. You don't need any device, you don't need any test, it doesn't cost anything, it's cheap, and it's prognostically valid. It has stood the test of time. However, it has some issues. One of the problems is that you can go back and forth from a class to another. So, for example, you can come at the hospital in class 4, very breathless, severely symptomatic. You get proper treatment, and you can be in a few days back in even class 1. And this can repeat itself. So in other words, it doesn't tell you by itself about the severity or the stage of the disease, because you can. This is another classification that was issued by the two American heart societies, that is American College of Cardiology, American Heart Association. And it's very important because it tells you about the gradual evolution from stage A to stage D. And in this sort of classification, there is no way back. So once you are in B, you cannot go back to A. Once you are in C, you cannot go back to A and B. In other words, it tells you more robustly where you are in your evolution of the heart failure. So basically A and B, it means the patient doesn't even have symptoms of heart failure. A, the patient is at high risk for heart failure, but no symptoms and no structural heart disease. Common example is hypertension or diabetes. These are two entities where we know the patient is at higher risk to develop heart failure. However, he doesn't have any structural changes in his heart and is asymptomatic. B, it means the same patient as in A, still asymptomatic, but this time you find some structural problem. To come back to the previous example, if the patient is hypertensive, you now find left ventricular hypertrophy. So this means that the hypertension is long enough to develop LV hypertrophy, which is a change in the structure of the heart, but he is still asymptomatic. And then stage C comes, and in stage C, you have both structural heart disease and symptoms. And please note, prior or current symptoms. That means even if you come to the hospital symptomatic, we get you the best treatment and you become asymptomatic, you will still be categorized as stage C because you once had symptoms. Okay? So you don't go back to B just because you currently don't have symptoms. And finally, stage D is very advanced heart failure, refractory to treatment, requiring specialized interventions such as ventricular assist devices, transplant, and very advanced interventions. So this is like an iceberg. So D is the tip of the iceberg, really very few patients, while A is a huge base of the iceberg, where you have millions and millions of patients who have diseases that could lead to heart failure. And the importance of this classification is that it puts emphasis on prevention already. So if I tell you you are in stage A heart failure, you suddenly become aware of the problem and you may wish to have a better treatment of your underlying condition to avoid developing symptoms of heart failure. And that's what we should do. We should treat very well the main causes of heart failure, and I'll get back to that in a minute. So if we put these two classifications one next to the other, what you can see is that for A and B, the patient is asymptomatic, so he will be in New York Heart Class 1. Stage C corresponds to classes New York 2 and 3, while stage D is most often patients very symptomatic, most likely close to class 4. So these two classifications you need to know, and you need to understand the differences between them and the philosophy, because again, for the American classification in stages, you also need some testing. It's not just by history taking, because you also need to assess the structure of the heart. So usually you do an echocardiography, but it gives you a better staging of where the patient is. Because obviously the prognosis of the patient will depend very much on where he lies on that. Now, the severity of heart failure depends on the stage. If you look at the New York Heart Association class and the way patients with heart failure die, you see there is quite different between New York Heart 2 and 4. A patient in New York Heart 4 usually dies from intractable heart failure, you see? And the proportion of sudden death is smaller here than in Heart 2, because if you are in a New York Heart Class 2, you are not so symptomatic. You will not die usually from heart failure, but unfortunately, you may die suddenly. These are proportions. Of course, many more patients in Class 4 will die, but within that group, most of them will die from heart failure. Much less patients will die in Class 2, but within that group, 2/3 will tend to die suddenly. So this is very important when we think also of the treatment that we choose. Now let us go to the causes of heart failure. You don't need to take notes. I will give you the slides, and also these slides, which have the logo of the European Society of Cardiology. I will also send you the slide set from the ESC so you can really look closely through this. So I'm just trying to highlight some of the things during the lecture, but then you'll have the chance to take a closer look and to study the slides in more detail. Importantly, a key cause of heart failure is ischemic heart disease. Basically, a patient who survives myocardial infarction will evolve with less viable myocardium, because when you have myocardial infarction, some of the myocardium dies, and depending on the extent of the myocardial infarction, you may end up with a very poorly contracted ventricle, and you may develop heart failure. So ischemic heart disease is a big topic. Toxic damage can come in the form of in many ways. It can range from recreational substance abuse, starting with common alcohol, and then this is quite rare, heavy metals, and more commonly and very hot topic nowadays is drugs. For example, cancer therapies. Now we have better ways of treating cancer, and patients with different types of cancer live longer. However, sometimes they will end up suffering from side effects of cancer treatments. And one of the side effects is developing left ventricular dysfunction and heart failure. Same radiation. You have to radiate the breast cancer, for example, and that may be good for the cancer, but it may have a side effect on cardiac function and it may lead to heart failure. Then you can have also a broader category of abnormal loading conditions, hypertension, valve or myocardium problems, pericardial problems, high output states like anemia or thyrotoxicosis, volume overload like in renal failure, and finally, last but not least, even arrhythmias, conduction disturbances, or more often tachycardias. If these are prolonged, if these are chronic, they lead to ventricular dysfunction. And we have an entity that is called tachycardiomyopathy. If the ventricle works for a long time at very high heart rates, it may develop dysfunction, but this may be reversible with the correction of the underlying rhythm. So basically, to put it in a different word, any insult to the myocardium in any form, if it is severe enough or long enough, may finally lead to heart failure. That's why heart failure is such a big problem, because it's like an end stage for any sort of disease that can affect the heart. This is also why it's so prevalent. Also, this is why it's not enough to say the patient has heart failure. You need not only to put the diagnosis of heart failure and the stage of heart failure, but it's crucially important to establish the cause, because very often, as it happens, the treatment depends on the specific cause. So we have also some other sort of causes that are much less common: immune-mediated or inflammatory diseases, infiltration, amyloidosis, hemochromatosis, metabolic derangements, genetic forms, and so on and so forth. Now, a few slides to remind you of some information from pathophysiology. So first, cardiac output. We know that this is basically the amount of blood that the ventricle ejects every minute, and it's calculated by heart rate multiplied with the stroke volume. That means the stroke volume is the amount of blood ejected with every beat. So if we multiply this with the heart rate, the number of beats per minute, then we get the output, which is the amount of blood ejected every minute. What are the determinants of ventricular function? What determines the stroke volume, which again is the key determinant of the cardiac output? So we have several key features. It depends on the preload, how well is the ventricle filled when it starts to contract. It depends on the afterload, that is the pressure that the ventricle has to contract against. And obviously it depends on the contractility of the ventricle. So these give the stroke volume, and obviously the heart rate and the effectiveness of the way that the ventricle contracts, wall integrity, valve competence, these will also influence, and altogether these factors will have an impact on the cardiac output. So whenever you have a problem, you need to think in these terms, because the treatment may be quite different. As I told you, you can have problems with the afterload in aortic stenosis. You can have problems with contractility in patients who survived myocardial infarction. You can have a tachycardiomyopathy, and the problem is because of the heart rate, and so on and so forth. And all of that, or a combination of them, may in fact affect your cardiac output. So when we talk about systolic dysfunction, nowadays we call it reduced ejection fraction, and commonly this is below 40%. There are a number of reasons that can lead to reduced ejection fraction. Most commonly loss of myocardium, impaired contractility from another cause, let's say a form of cardiomyopathy or myocarditis, loading, overloading of the ventricle, either by pressure like in aortic stenosis or by volume overload like in mitral regurgitation. And then this will lead to a reduction in cardiac output with or without hypoperfusion, and it will often lead to increased LV volumes that can lead to increased pressure backwards with pulmonary congestion. So basically, the way a patient develops symptoms, it usually starts in the ventricle. The ventricle has some sort of a problem that leads to an increased pressure. This is reflected backwards by increasing the pressure in the left atrium. Remember that the left atrium and the left ventricle are in close contact and open to each other in diastole. So if you have an increased diastolic pressure in the ventricle, you will also have an increased pressure in the left atrium. And this will reflect backwards through the pulmonary veins, leading to an increase in the pulmonary capillary pressure, which may lead to pulmonary congestion. So this is the backward process leading to dyspnea. On top of that, the heart and the body in general tries to compensate for these changes by activating some systems. Usually there is neurohormonal activation. Some hormone systems are involved in maintaining the normal homeostasis: systemic sympathetic nervous system, renin-angiotensin-aldosterone system, and vasopressin, the antidiuretic hormone. And these systems become very upgraded, titrated, so to say. They become very much active. And the current paradigm of heart failure treatment, you'll hear more about that tomorrow, is to also attack and compensate the upregulation of these neurohormonal systems, because we know that the activation of these systems is in the long term deleterious to the heart. So if you have a decreased arterial pressure, this will lead to an activation of the sympathetic nervous system, and it will lead to improved cardiac output through tachycardia and increased contractility, but it will be deleterious in the long term. Similarly, things happen with the renin-angiotensin-aldosterone system that is activated by the reduced renal perfusion, and it leads to salt and water retention, sympathetic augmentation, vasoconstriction, again, in order to keep the cardiac output normal, but in the long term, it is deleterious. Now, how do we assess diagnostically a patient with new onset heart failure? First of all, we need to determine the type of cardiac dysfunction. Is it predominantly systolic or diastolic? Is it with reduced ejection fraction or is it with preserved ejection fraction? Secondly, we need to determine the cause, as I told you. We need to define prognosis, and based on all of that, to guide treatment. I will not go through all these lists. Again, you will have it. I will rather just tell you a few things. We have symptoms and signs. We have typical and less typical symptoms. We have signs that are more specific and less specific. But whatever we look for, remember that there is no single sign or symptoms that is 100% sensitive or specific. So it means that we need to be aware of the differential diagnosis of each of them and to put everything in context. And this is also why you need to rule out alternative causes for those symptoms, and you also need to assess the cardiac structure and function in order to see whether there is an underlying condition likely responsible for the clinical picture. Now, one additional problem is that in patients who are already treated with diuretics, for example, hypertensive patients that get diuretics for their hypertension, this may mask the more specific signs, because the more specific signs are often related to fluid overload, and because the patient is treated with diuretics, this fluid overload may not be so evident. So remember that fewer signs are related to reduced oxygen delivery, and this is why we need to be careful and not rule out heart failure, even if the patient does not have clear-cut signs of heart failure. But this is why it's important to also look at the comorbidities of the patient with heart failure. For example, a patient who has respiratory problems, an old smoker with chronic obstructive pulmonary disease. The patient may have dyspnea because of the pulmonary condition. So one cause is it may interfere with the diagnosis itself. Secondly, it may make heart failure symptoms even worse because they come on top of other symptoms, and it may lead to an additional impairment in the quality of life. And this can contribute to the burden of hospitalization and mortality and may add up to the cause of readmissions. Now we have an algorithm, a diagnostic algorithm for heart failure of non-acute onset. And here you have the patient coming and you have a suspicion. So what do? You try to see, is this likely to be heart failure? If the patient has a history of MI, if the patient has rales, a heart murmur, an abnormal ECG, you have a high likelihood, okay? If any of them, if none of these is present, you think, well, I don't find much. Heart failure seems unlikely. Maybe I look for another cause, okay? In between, you may say, well, it might be or it might not be. Maybe I will draw some blood to measure natriuretic peptides level. In any case, if there is a likelihood, a suspicion of heart failure, you will end up at some point by doing some echocardiography, because you will need to look at the heart. This will help you confirm the diagnosis of heart failure, and even more important, if this is confirmed, determine the etiology and start the appropriate treatment. Now, there may also be factors triggering acute heart failure. Commonly, acute coronary syndromes comes with acute heart failure. Sometimes there is a huge increase in blood pressure, and this leads to acute heart failure. Sometimes an infection leads to this. Sometimes non-compliance, the patient eats salty things, and so this accumulates fluid and leads to unmasking of heart failure, and so on and so forth. So you need to look carefully at any of these, because these may, on one hand, explain the exacerbation of heart failure, on the other hand, may be a therapeutic target. Why do we make a difference between acute and non-acute setting? First of all, because symptoms are quite different, much more severe in the acute setting. Signs are also quite often different. Again, they may be absent in the chronic setting, particularly when the patient is treated with diuretics. And then even the way we use our diagnostic tests are quite different. If we use BNP, natriuretic peptides, the cutoff levels that we use for normal versus abnormal may be quite different. And obviously, last but not least, the treatment may be pretty much different. How do we investigate a patient with suspected heart failure? We have essential initial investigations. And these are from starting with simpler one, ECG. It's basically done in every patient. Natriuretic peptides, they have their role. I'll get back to that. Because it's a simple blood test, a nurse can draw blood. You don't need sophisticated machines or high level of expertise. You just draw this blood and do the test and get the measurement. And echocardiography, which offers a wealth of information. However, you need the echo machine. You need someone able to do the echo and to read it properly. So it's a bit more complex. However, nowadays you cannot really investigate a patient for heart failure without performing an echo at some point in time. The only question is how fast you go for echo. And this also depends on the setting. If you are in the hospital, you will do an echo right away because it's available and it will answer lots of questions. If you are in a private office, a GP, they may not have an echo, they may need to schedule for an echo, so they will try to sort it out with natriuretic peptides and other simpler and more available things. How about the ECG? How do we use the ECG? So this is a paper published some years ago, 2004. You see this looks at 4 studies, and they found that the abnormal ECG identified left ventricular systolic dysfunction with a sensitivity ranging from 73 to 94. So not so bad, not ideal perhaps, but remember it's a cheap test. But the real value of the ECG is when it is normal. So if you have a patient with suspected heart failure, but you find a completely normal ECG, it is very good because this has a good negative predictive value. So if the patient comes with acute onset of symptoms and the ECG is completely normal, then the likelihood of acute new heart failure is really very low. You can virtually exclude it. Even if the presentation is non-acute, if the ECG is completely normal, then the likelihood is quite low, 10 to 14%. The ECG obviously can show a number of things, starting with an abnormal rhythm, may show you atrial fibrillation, may show you abnormal intraventricular conduction, left bundle branch block, atrioventricular block, and so on. It may show you the features of the underlying condition, LV hypertrophy or Q waves, that is, the history of the old MI, indicating there is no viable myocardium in that area. And this shows you there is a problem, and it also points to the possible cause of heart failure. If you see Q wave from V1 to V5, it's basically large anterior infarction. So you may already think of a reduced ejection fraction with consequent heart failure. And again, heart failure is very unlikely in patients presenting acutely and who have a completely normal ECG. Now, whenever availability of echo is limited, an alternative approach to diagnosis is measuring the concentration of natriuretic peptides. Basically, these are hormones, peptides, that are increased whenever the heart is diseased, whenever the pressures inside the heart are increased. So you will find higher levels of natriuretic peptides, and this will tend to correlate with the severity of the disease. Even with peptides, the best use of them is also exclusion. So again, if you have someone coming with heart failure and you find a completely normal peptide level, this may safely exclude heart disease as a cause of symptoms, and so you look for an alternative cause of the patient's symptoms. And here, again, we have different cutoffs that we use, and again, you see pretty good negative predictive value. A normal BNP virtually excludes acute new heart failure. However, if we talk about non-acute heart failure, then we have to use a much lower threshold for the BNP and for the NT-proBNP. Basically, the principle is that a normal ECG and or a normal natriuretic peptides questions your diagnosis of heart failure. On the other hand, if these are increased and not severely increased, things get a bit trickier because there are a number of conditions where these peptides may also be elevated. So these are that can either be cardiac or non-cardiac, and that you will need to keep in mind in case you have a mild increase in natriuretic peptides. So if it's normal, it's very helpful. If it's increased, you need to judge it in context. So again, getting back to what I've told you before, classes of recommendation. We have class 1 to do an ECG. We have class 1 to do a chest X-ray. And chest X-ray you don't do basically to make the diagnosis of heart failure, but the important role is that it may exclude alternative causes of the symptoms of the patient. For example, it may exclude a pulmonary problem, or it may detect a pulmonary problem that may be responsible for the patient's symptoms, contributing to dyspnea. So, and then of course you do some blood tests, and the importance of blood tests relies not only on finding ways to support your diagnosis, but they are also related to the treatment that you're going to select. It's very important to know the renal function. It's very important to know sodium and potassium, because this will be influenced by your treatment. Of course, it's important if the patient has diabetes or not, if the patient has a problem with thyroid function, because I've told you this either hyperthyroidism or hypothyroidism can lead to heart failure. And basically, all of that belong to the basic battery of tests that we do in a patient with suspected heart failure. So you see recommendation class 1, however, the level of evidence is C. We don't have large trials to support that, but it's an expert consensus that this is important to be used. So again, back to what I've told you, heart failure with reduced ejection fraction, we just need symptoms and signs of heart failure plus the evidence of reduced ejection fraction. And for mid-range and preserved, we need symptoms and signs, we need to measure EF, but we also need some evidence of a problem, either elevated peptides and at least one criterion related to structural or functional changes in cardiac function. And now back to echo. Echo is crucial because it provides immediate information starting from systolic, diastolic function of the ventricle, the thickness of the walls, and valvular function. And this information is crucial, especially ejection fraction, because I told you the treatment is pretty much different. If the patient has reduced ejection fraction, we know a lot of therapies will help. If the patient has preserved ejection fraction, the approach will be completely different. You'll hear more about this tomorrow. Now I'll just show you a few examples. I take it that you saw some echocardiograms by now. So for easiness, I've put in comparison a normal heart here. And you can see the shape of the heart is the shape of a bullet with the long axis much bigger than the short axis, with good contractility. So this ventricle has a normal size and a normal contractility of the segments that we see and the normal estimated ejection fraction. On the opposite, this heart has a much larger, much more dilated ventricle. The shape is more spherical. You see it? It's no longer like a bullet, it's more like a sphere. Contractility is reduced and ejection fraction is significantly reduced. Of course, we need to measure it, but an eyeball estimate tells us this is significantly reduced below 30. But this is heart failure with reduced ejection fraction. This is another example, and you see in the same patient both parasternal long axis and apical 4 chamber, and you can see again this time there is a reduction in contractility throughout the ventricle, quite diffuse, and also ejection fraction is clearly below 30. And we can think this might be dilated cardiomyopathy. You do not see a clear scar from a previous infarct, but you see a diffuse reduction in LV contractility. And here's a patient who came with symptoms of heart failure, but who has a pretty normal ejection fraction. The ventricle has thick walls, that means left ventricular hypertrophy, with very good contractility, and ejection fraction is above 60, is totally normal. However, if you see the ECG, you will see clear signs of left ventricular hypertrophy with a high voltage and also clear changes in STT. So this is a totally different story. And then I also showed you this image in our initial course. This is about the cause of heart failure. Anyone wanted to comment on that? This patient has heart failure. What is the cause of heart failure? Are you sleeping? Anyone guessing? If you look at the valve,
maybe mitral stenosis.
mitral stenosis. Very good. You see, it doesn't open at all. Basically, let me show you. Sorry. You see, this is a normally opening mitral valve, so it opens freely, no problem. Now, if you go back to this, this is not opening at all, and in fact, there is a very narrow orifice. But what about this valve? Does it seem to open? It doesn't.
No, it's calcified.
No.
It doesn't open at all, you see. So this patient has both severe mitral stenosis and severe aortic stenosis. And also, inside the left atrium, there is something here. What is this?
Thrombi.
Most likely. Okay, so with echo, we cannot say for sure, but what we can say is the patient has a mass, we define it as a mass inside the left atrium, and provided that this is a patient with severe mitral stenosis, it is very likely that this is a thrombus in the left atrium, quite common. So you saw that patient has heart failure. I already know the treatment because I know that in this patient I need to operate the valves and the patient may get rid of heart failure. Of course, it's not that easy, but in fact, this patient, you don't apply, ACE inhibitors and things, and because you need to go to the cause, and the cause are the valves. So you need to treat the valves. That's another example. This is the same normal patient that I showed you before. And that's another one. Here you see the ventricle is a bit enlarged, but the ejection fraction is pretty good, is 65%. However, here what you see is that the mitral valve is ruptured and it goes completely inside the left atrium in systole. So this is severe mitral regurgitation because of the ruptured mitral valve, because this patient had infective endocarditis that led to the rupture. And in fact, this white thing here is a vegetation attached to the anterior mitral leaflet. So again, you will know if this patient has heart failure, you will need to operate on the valve. Of course, you will need to keep in mind the infectious status, antibiotics, and all the things. But again, the role of echo is that it shows you exactly the cause. What about this one? Any suggestions? So this is the normal 4-chamber heart. And this one, this is really a survivor of a huge infarct, because you see this is a huge left ventricular aneurysm. So the only thing that contracts from this ventricle is only the base. You see the contractility is good here, and is good only here in this segment. But more than 2/3 of the ventricle doesn't move at all. So this patient has an ejection fraction of 20%, very much reduced, because he lost a lot of myocardium by having his large anterior myocardial infarction. And now the consequence of this is heart failure. So you will know again the cause if you see this image. So if you go back to the guidelines, and again, I'm not gonna read all that, just to show you that we have recommendations for the use of echo, and basically it helps in many aspects: myocardial structure and function, measure ejection fraction in order to categorize the type of heart failure. Also, based on the level of heart failure, you will select the best treatment. You not only look at the left ventricle, you will also look at the valves, at the right ventricle, at the pulmonary pressure, okay? And you will also have to do echoes in patients who are exposed to treatments that can potentially damage the myocardium. We also have advanced methods that we use, but it's not the scope of this lecture. So we don't just do ejection fraction, we can also measure the deformation of the myocardium with new technologies that in some cases may provide additional information. So again, regarding applied diagnostic measurements, we tend to do natriuretic peptides in all patients with acute dyspnea and suspected acute heart failure to help differentiate acute heart failure from other causes of acute dyspnea. We do 12-lead ECG, chest X-rays, blood tests, and we do echocardiography in patients who are hemodynamically unstable. We do it immediately because they may need immediate treatment. And if patients, we know if we have a previous echo and we know the cardiac function, we can do it within 48 hours. There are some other imaging tests like cardiac magnetic resonance, SPECT, CT, or you can do coronary angiography, and these are generally indicated for specific reasons. For example, cardiac MR is excellent in measuring the size of the left ventricle, the size of the cavities, the volumes, the function, the ejection fraction. It has a spatial resolution better than echo. You can do it in every patient. But the problem is that this cannot be done in critically ill patient. If you have a patient who is acutely ill or is in intensive care, you cannot simply move the patient and you cannot put the patient in a magnet. So echo is still the first line. CMR can be useful as a second line, okay? So it's recommended to assess structure and function in patients with poor acoustic window and in specific subsets of patients like patients with congenital heart disease. Another indication is if you want to look at the structure of the ventricle, at the structure of the myocardium, when you suspect a specific form of heart failure, infiltrative problems, inflammatory problems, then CMR provides additional information and is better than echocardiography. But as a rule of thumb, we usually start with echo in every case, and then depending on what echo brings, sometimes we may wish to add CMR. There are a number of other things. Invasive coronary angiography is recommended if the patient has angina that does not respond to pharmacological treatment in order to clarify whether the patient has coronary disease, what is the severity, and what is the best treatment. And also reassessment of structure and function by non-invasive imaging is needed in specific situations like worsening symptoms of heart failure, or in patients we treated well, but we wish to measure again ejection fraction before recommended device implantation, and again in patients who are exposed to therapies that may affect myocardial function, like chemotherapy for cancer patients. So to conclude, heart failure diagnosis is based on symptoms, signs, and finding structural or functional cardiac abnormalities. There are different diagnostic approaches in acute versus non-acute onset. The cutoff values for natriuretic peptides are different in these two settings. Class 1 recommendations for diagnostic approach is for natriuretic peptides and echo, 12 lead ECG, some of the lab tests that we've discussed, and chest X-ray. If we talk about preserved ejection fraction, you need to provide evidence of LV diastolic dysfunction. And this is very important. Once the diagnosis of heart failure is confirmed, you always need to determine the cause in order to properly guide the treatment. Now, I have put here a few questions, and you may want to answer right away. I've told you about stroke volume. The stroke volume is the volume of blood ejected by the ventricle with each beat. So which are the factors affecting stroke volume? 3 of them are affecting the stroke volume. The 4th,
afterload and cardiac and contractility.
Cardiac output.
yeah, the correct answer is cardiac output. Okay, so preload, afterload, contractility all affect stroke volume, but the cardiac output is not determined by this. Okay, so the cardiac output is the effect of stroke volume, is not the cause. Now, what about this one? The following are typical symptoms of heart failure, except for
Coughing?
right. Coughing is not so specific. Coughing can be due to several other things. And here, I think that's easier. Single most important diagnostic test. If you have to choose just one of that.
Echocardiography?
Sure, yeah, because it, among all this, it provides you, most of the information. Of course, it's also the most expensive, but the question is not about how expensive it is, but which is most important. Okay, so that was basically the lecture. If you have any questions. If you don't have questions, I will send you the slides and the slide set from the ESC guidelines. Read them carefully. This is an important topic. There will be also questions at the exam, obviously. And basically tomorrow you will have a second lecture on heart failure that will be about the treatment of heart failure. Any other things to share with me? How are things going? I hope you got vaccinated, those of you who wanted. We did our best to make this possible, and you were on the list. Thanks to Miruna, who was helping a lot. We'll keep in touch. Basically, the plan is that at 3 weeks, those of you who got vaccinated will get the second dose. So basically, it's from this Friday in 2 weeks, but we'll have the chance to discuss more until then. And also, we'll have 2 more lectures together about hypertension. They are scheduled on Thursday and Friday. I will see, might have a change for Thursday, but in any case, I'll talk to you and also tell you a bit more even about the exam. So try to be active, try to benefit from the days you spend in the hospital and see patients, because this is a difficulty in finishing this rotation without seeing many patients. So try your best for this, and also attend all the seminars. These are in fact obligatory. It's not, you have to attend them, and it's also a pity to lose them because you can learn a lot of things, and my colleagues try their best to show you different things, and you can ask them whatever you want to, whatever things are unclear. So try to benefit as much as you can under the circumstances, the unfortunate circumstances of this pandemic. But in any case, you should progress and you should be prepared for the exam. Okay, if there are no questions, then I wish you a good day.
Thank you.
We'll meet soon again. Okay, bye-bye.